Good morning, everyone. I'm very happy to have the opportunity to participate to this session. I was requested to present a clinical case and I've decided to discuss about past resistance mutations and ART optimization in one HIV-infected patient with cancer. This man is a 65-year-old man. He is costume designer for theater at La Comédie Française. He is married with a HIV negative man. His HIV infection was diagnosed in 1994 and he is treated by ART since 1996. Before the beginning of the treatment, his HIV viral load was approximately 100,000 copy per ml and his CD4 nadir was 180. He had never presented opportunistic infection. He is currently on etravirine plus raltegravir once daily and his HIV viral load is undetectable. Here you can see his virological history with the initiation of ART in 1996 by zidovudine plus didanosine. He continued to present a viral replication until 2005, so during 9 years despite his treatment, and from 2005 he has achieved an undetectable viral load. When you see him at hospital during a routine visit, he reports a clear deterioration of his general condition with a weight loss of 8 kilograms for 6 months with anorexia and asthenia. He had a chronic cough with dirty sputum and he reports an intermittent macroscopic hematuria. His biological tests show an anemia with hemoglobin at 9.4, an acute renal failure with plasma creatinine at 160, and a moderate inflammatory syndrome with CRP at 31. So you give him a prescription for a CT scan and for a bladder ultrasound. The CT scan shows bilateral emphysema, but no lesion suspicious of cancer. By contrast, the bladder ultrasound shows a big mass on the posterior side of the bladder with a dense vascularization, and as a consequence, you refer the patients to an urologist. A tumor resection was performed by endoscopy, and the histopathology examination shows a high-grade papillary urothelial carcinoma with necrosis infiltrating the muscularis. So the tumor is classified as a T2 high-grade infiltrating bladder carcinoma. And in France, we have a national network and working group called CancerVie. And this group provides a meeting, a multidisciplinary committee every 2 weeks to discuss cases of cancer in HIV-infected people. This committee provides recommendations for cancer management and ART adjustment regarding potential drug-drug interactions. For this patient, the committee recommended a neoadjuvant chemotherapy by methotrexate, vinblastine, adriamycin, and cisplatin. And the recommendation was also to stop etravirine because an interaction with chemotherapy. Antineoplastic and antiretroviral drugs share metabolic pathways, especially cytochrome P450, which can generate drug-drug interactions. Etravirine strongly induces cytochrome P450, and the risk is the inefficacy of the antineoplastic treatment. By contrast, boosters like ritonavir or cobicistat inhibit cytochrome P450, and the risk in this case is a significant increase in concentrations of antineoplastic drugs with a risk of severe side effects. In much less frequent cases, it's the cancer treatment that can modify the concentrations of ART with a risk of virological failure. On the right, the table summarizes the drug-drug interaction between ART and chemotherapies, and you can see in purple that the main interactions are due to boosted PI or boosted elvitegravir because of ritonavir or cobicistat, and in blue due to NNRTI, except for rilpivirine and doravirine. So back to our patient, we have to change his anti-HIV treatment to remove etravirine. The first element we have to know is the therapeutic history. As you can see, he has presented a sustained viral replication in the past on NRTI, PI, and NNRTI, suggesting the existence and the accumulation of resistance mutations on the RT and the protease genes. Two resistance genotypes were performed from blood plasma on 2002 and 2005. Here is the result of the cumulated HIV-RNA genotype from these two genotypes. He has several mutations on the RT gene, including K65R and M184V mutation, conferring resistance to all NRTI, including tenofovir, and all NNRTI, except for etravirine and doravirine. There was no impact of mutations on the sensitivity to PI, and the integrase gene was not sequenced, but these patients did not experience viral replication on anti-integrase, so we can hypothesize that he has no resistance mutations to anti-integrase. Now, the question is it necessary, interesting to have a resistance genotype from HIV DNA after 15 years of undetectability to know if the mutation existing on the HIV-RNA genotypes of the past are still present in the HIV reservoir? Of course, we have carried out this HIV DNA genotype, but before the findings, we can have a look on data published in the literature about the performance of HIV DNA genotype. There are several studies having compared the resistance mutations found on genotypes from HIV RNA and DNA in the context of viral suppression. For example, this study conducted by Constance Delogère has demonstrated that the number of mutations was always lower on DNA genotypes in comparison with RNA genotypes, whatever the treatment studied. On this slide, NRTI and PI. The second study conducted by Mark Virdon had the same conclusion. So today, most teams agree that in clinical practice, it's more useful to have historical RNA genotypes. But if RNA genotypes are not available, a DNA genotype could be an alternative. Indeed, DNA genotypes seems to have a good positive predictive value when compared to past RNA sequencing, but negative results from PBMC must be interpreted with caution. In other words, the fear is not to detect mutations from the past due to lack of sensitivity of the DNA genotype. However, another explanation could be these mutations are not detected in HIV DNA because of a real recurrence of the mutation after 5, 10, or 15 years of undetectability in HIV reservoir. At the top of the screen, you can see again the result of the cumulated HIV-RNA genotype, and at the bottom of the screen, you can see the result of the DNA genotype. Almost all the resistance mutations have disappeared on the RT gene, and if we take account only this genotype, the HIV strain of this patient is fully sensitive to all antiretrovirals, including NRTI and NNRTI. This case illustrates what we said just before. And the question is, should we trust past RNA genotypes or current DNA genotype? This question is very important to patients like this patient who absolutely need a change of heart despite numerous virological failures in the past. To answer this question, it's interesting to have a look on this recent study having demonstrated the progressive decrease in the resistance mutations in HIV DNA over time. 25 patients were included with at least 5 years of viral suppression, with at least one mutation associated with NRTI or NNRTI resistance on a past HIV RNA genotype, and with no therapeutic pressure, so with no NRTI or NNRTI for at least 5 years. New generation sequencing was performed every year during the last 5 years, and the study shows the stability of HIV DNA over time, the clearance of 72% of mutation at the last point, and a progressive decrease in the proportion of minority variants with resistance. So this study is in favor of the clearance of resistance mutations in HIV reservoir in patients with sustained viral suppression, which could allow the recycling of antiretrovirals despite resistance acquired in the past. So what we can do for this patient? In this context, we need ART able to maintain the viral suppression, of course, without nephrotoxicity and without drug-drug interaction with chemotherapy. So can we give taf-FTC bictegravir, abacavir, 3TC plus raltegravir, boosted darunavir plus raltegravir, dolutegravir rilpivirine, dolutegravir raltegravir, dolutegravir, or dolutegravir plus lamivudine? We decided not to propose taf-FTC BIC because of the past resistance to tenofovir and lamivudine. We decided not to propose abacavir 3TC plus raltegravir because of the past resistance to abacavir and lamivudine. It was not possible to give boosted PI due to the interaction between ritonavir and chemotherapies. We decided not to propose dolutegravir rilpivirine because of the past resistance to rilpivirine. In this patient, we chose not to take account the result of the DNA genotype because we had alternatives, and we hesitated between doravirine raltegravir and doravirine dolutegravir, although there is no data on the efficacy of these two dual therapies. For information, there are two ongoing clinical trials studying doravirine raltegravir and doravirine dolutegravir. Finally, we chose doravirine plus dolutegravir. Another option could have been dolutegravir lamivudine despite the past resistance to 3TC. Indeed, there is some evidence of efficacy of this dual therapy despite a historical M184V mutation. The MobiDeep experience has demonstrated that lamivudine, in association with darunavir ritonavir, was able to maintain the virological success, and that was not the case in the absence of lamivudine in patients who had a M184V mutation in the past in 97% of cases. More recently, that's the slide, our Italian colleagues have showed in a retrospective cohort that this mutation had no significant impact on virological control in patients on 3TC-based dual therapies, including 24 patients on dolutegravir lamivudine 3 years after switch. However, the number of blips was significantly higher in patients with M184V mutation in comparison with others. Also, the French Dolulam experience has shown a sustained virological efficacy of dolutegravir 3TC in 10 patients with previous M184V mutation. So overall, these studies suggest that dolutegravir 3TC could be a good option for patients with previous virological failure on lamivudine. However, in this patient, we did not choose dolutegravir lamivudine because we had other alternatives, and we chose doravirine plus dolutegravir. 6 months after the switch, the plasma viral load remained below 50 copies per ml. And for the cancer treatment, the patient received 4 cycles of methotrexate, vinblastine, adriamycin, and cisplatin, and then was operated with a complete cystectomy. To conclude, I would like to give you some key points from this clinical case. Cancer is now a major concern in aging HIV-infected people. Anti-neoplastic treatment is always the priority, and there is no restriction, no contraindication due to HIV status. So HIV treatment ART must be adapted to avoid drug-drug interactions. Ritonavir and cobicistat and the first generation NNRTIs frequently generate interactions. Past virological failures and the past acquired resistance mutations complicate the modification of ART. And finally, HIV-DNA genotype may be useful in patients with sustained virological suppression and could help to recycle drugs in case of previous resistance. Thank you very much for your attention, and I would like to thank all my colleagues of the Conservi, and Oncovi study group. Thank you.